I've actually now really the honor to present you now our nationwide study on the outcome and complications of arthroscopic rotator cuff repair in Switzerland. So I hand this to you. And yeah, this is actually a study I've been working on for over 7 years to go together with Laurent Odiger. And it has been performed within the framework of the shoulder expert group of Swiss Orthopedics. And actually, we wanted to split up this talk in 3 parts. And so Laurent would have talked on the adverse events. I would talk on methodology and outcomes, and Conny Baum, who's sitting here, will show what we have found about the sensitivity of ultrasound to assess the repair integrity. But unfortunately, Laurent cannot be here today. He lost his wife last Friday in a very tragic accident. So life can be very hard and unfair, and my thoughts are with Laura. And so Thomas will take over some parts of his talk. So we have no conflict of interest related to this talk, but we would like to dedicate it to Annette Odiger, the wife of Laura. So what was the rationale of this study? So I think when we have to decide whether or not to operate in a patient with a rotator cuff repair, we usually base our decision on factors that could indicate a good or bad healing of the repair. You know, all these factors, they have been discussed throughout the day. And actually, we have known these factors for a very long time. So they've been around for over almost 30 years. And meanwhile, we have seen the slide before, there's this exponential increase of scientific studies. And even though these studies integrated these factors into our decision-making, we only see a slight improvement of repair integrity following our repairs. And most importantly, we do not see any change in the subjective and objective outcomes over the last 30 years. So what does that tell us? I think one factor is also that probably have not found the ideal selection criteria for our repairs. Probably should search for more predictive factors that could indicate a good outcome and thus would improve our surgical outcomes as well. So we first thought probably there are more of these factors out there in the literature and we simply do not know. So together with Thomas Stoyanov, who at that time joined us as a PhD student, we screened the literature for factors that could somehow predict the functional outcome following the repair. And you can see we screened over 6,000 articles, and finally we could only identify 24 articles that were eligible inclusions. And we found only 2 prognostic factors that could indicate a good outcome or somehow predicts the outcome: age and hair size. So factors we have actually already known. So this was a bit disappointing. And on the other hand, when we have to decide for or against surgery, we should not only be able to estimate the outcome, we should also have an idea about the likelihood of a complication a patient might sustain after the repair. But this is extremely difficult to do so based on the current literature, because there are no uniform definitions of complications following arthroscopic rotator cuff repair. And this strongly applies to shoulder stiffness after rotator cuff repair. We have actually also screened the literature, over 600 articles, and we found over 16 different definitions of shoulder stiffness following rotator cuff repair. And thus, there's an extreme variability for this complication reported in the literature. And now we're a bit in a dilemma, because this is not what our patients want. They want to know what happens to them when they undergo surgery. They would like to know about the costs and the benefits of the procedure. And I think this need called for a large registry where we would record all our arthroscopic rotator cuffs when using standardized outcome measurements, and not only for the outcomes, but also for the complications. And so for having such a standardized outcome sets, we developed this using a Delphi process among 61 shoulder experts around the world. And we created this core event set, which not only includes clear definitions for outcomes, but also for complications. And also we validated using already existing registry here at Schultes Clinic in Zurich. And so we asked ourselves, could we really apply this in a large patient registry? So Laura and I decided to go for this nationwide study. And our main goal was actually to build robust prediction models to somehow estimate the outcome following the repair at 6 and 12 months after surgery, and also to somehow estimate the likelihood of a shoulder stiffness following the repair. But we also wanted to collect the data about the safety of the procedure, so all other adverse events should be collected using this core event set I just showed you. And of course, we wanted also to assess some other secondary outcomes like the repair integrity, return to work, etc. And we included in this study all adult patients undergoing a primary arthroscopic repair for a partial or full thickness rotator cuff tear. And sample size calculation indicated that we would need around 970 patients. And so this calls for a multi-center cohort. So we were able to enroll 18 sites in Switzerland and the Charité Clinic in Berlin for this study. And in all of these clinics, patients underwent prior to repair a very thorough baseline assessment. So we did not only collect the functional scores, but also scores rating the level of depression, anxiety, quality of life, work status, etc. Then at the time of surgery, every surgeon had to document his repair very thoroughly, what kind of technique he used. And then at 6 weeks follow-up, we collected all the data about the rehabilitation, duration of immobilization. And then at 6 and 12 months follow-up, we collected again the functional outcome, and all these scores we collected at baseline. And this was then again repeated at 24 months. And repair integrity was assessed at 12 months in all patients using ultrasound. And in a subgroup of 310 patients, we performed an additional MRI. And what's important is that at all time points, patients were asked if they had sustained an adverse event after the surgery. For the organization of the project, we founded a scientific board where all the PI of all the sites were sitting together. And what was important is that all the PIs were allowed to use the data for their own scientific projects. And this ensured a lively scientific interaction among the group. And it kept also the motivation for recruitment high, because we were really able to recruit all patients in a very timely manner. So these 970 patients were recruited from June 2020 to November 21, even though COVID kicked in at this time and reduced the numbers of arthroscopic rotator cuff repairs substantially. And due to the high motivation of the group, we were not only able to enroll all the patients in a timely manner, but we also could follow them almost completely. So we had 24 months follow-up. We had a follow-up rate of 88%, 12 months, 90%. Overall, the data completeness is 95%. So this is the first lesson we learned from this study. You can only do that in a team, in a group. You can't do it yourself. And you must have a group where everyone is willing to achieve the same goal and is also ready to go beyond his comfort zone. So this is the tear profile of our cohort. So we had 15% partial tears, and we had 26% single tendon tears, and overall we had 44% massive tears. So a very nice distribution of the tear pattern. And this is now already the outcome scores shown on this graph, and you can take several information from this curves here. So first you can see that at baseline there's a high variability among patients. And that's what we also saw. I mean, a rotator cuff repair, for example, in a public hospital is not the same as in the private hospital. We saw that baseline score was a bit lower in the public setting than in the private setting. But what you then can see is that this variability reduces over time, and we could see all over our cohort the significant improvement of all outcome scores. And if you can see that at final follow-up, we had a really satisfactory result in most patients. However, we saw that in 10 to 15% of patients, we could not see a significant improvement. And so we asked ourselves, who are these patients? What are the factors that could somehow label them or predict a worse outcome? And to that end, Thomas and Laurent created a prediction model for the Oxford Shoulder Score at 6 months, so the subjective outcome score at 6 months. And they tried to identify these factors that could indicate a poor result. And it's a very complex procedure to do this. Thomas will show you later a bit how you do that. In essence, you first have to collect or somehow make a Delphi process among a shoulder expert to identify potential factors. You look up the literature, and then usually using a linear mixed model, you can then identify those factors that really matter. And you can see the factors that were left in the end, they are all patient-related. So depression and anxiety had a major impact at baseline, had a major impact at the result at 6 months, the level of education, the type of occupational position at work, so the socioeconomic status, and also the baseline Oxford Shoulder Score. So it's all more or less patient-related, and you can't influence it, as a surgeon. So we also looked at techniques, etc. It didn't matter. In the end, only patient-related factors remain. So this shows that I think the patient's perception, how he looks at what you're doing, and how he also rates the results personally, because it matters probably most. Yeah. So now we move over to the complications so that we could somehow assess the severity of the complications that occurred in the postoperative period. We had to create a new grading. So we used or developed and validated modified Clavia-Dinto classification. In this classification, grade 1 would be an adverse event that would not require any specific treatment. A grade 2 would require pharmacological treatment. A grade 3, a revision surgery, but not an arthroplasty. And a grade 4 would mean that the repair had to be converted into a reverse shoulder arthroplasty. And a grade 4 would also be the case if you have sustained a life-threatening complication like a pulmonary embolism.